Good afternoon. On behalf of the Pennsylvania Patient Safety Authority, I'd like to welcome you to this webinar titled Pennsylvania Patient Safety Reporting System, Understanding and Applying Criteria. My name is Terry Lee Roberts, and I'll be your moderator for this program. Now, I'd like to introduce you to our speakers for the webinar, Sharon Bradley and JoAnn Adkins. Sharon Bradley is a registered nurse and board certified in infection control epidemiology, CIC. She is a senior infection prevention analyst with the Patient Safety Authority. She has practiced for over 45 years in clinical, education, risk, administrative, and patient safety roles in both acute and long-term care. Sharon has authored multiple infection prevention control journal articles and has provided educational programs on infection control topics at local, state, and national conferences. She serves as a director and chapter legislative representative on the FAPIC Philadelphia and Delaware County Board of Directors. Sharon Adkins is a registered nurse and a senior infection preventionist for the Pennsylvania Patient Safety Authority. In her role at the Pennsylvania Patient Safety Authority, she works with healthcare facilities to improve patient safety through infection prevention initiatives. JoAnn has presented educational programs on infection control topics at the local, state, and national levels and has authored infection prevention and control articles. She is board certified in infection control and epidemiology, CIC, and a fellow of the Association for Professionals in Infection Control and Epidemiology, FAPIC. JoAnn is a member of the Association for Professionals in Infection Control and Prevention, AFIC, the Sigma Theta Tau International Honor Society, and the Central Pennsylvania Association for Healthcare Quality. JoAnn, ladies, I will now turn the program over to you.
Thank you, Terry Lee. Healthcare-Associated Infection Prevention and Control Act of 2007, Act 52, requires long-term care facilities to report specific healthcare-associated infections to the authority and the Department of Health via the Patient Safety Reporting System, using nationally recognized guidelines and definitions. Surveillance for and identification of infections by the application of criteria is a needed skill for the infection prevention designee. This webinar will discuss the application of criteria to identify infections, review the reporting timeframes, and provide strategies on how to utilize the data you are collecting to improve resident safety. I'm going to turn the program over to you, Sharon.
Thanks, JoAnn. Okay, well, welcome everyone to our webinar. And so today we're going to discuss the application of the PACER's reporting criteria to identify infections. We'll talk about reporting timeframes and give you some specific strategies on how to use the data you're collecting to improve resident safety. So a little bit of history. In 2002, the Pennsylvania legislature passed Act 13, also known as the MCARE Act. MCARE required Pennsylvania healthcare facilities to report incidents and serious events in which patients were potentially or unintentionally actually injured. MCARE also required written disclosure of serious events to the patients or their families. Now, this law gave birth to the Pennsylvania Patient Safety Authority. We're an independent state agency which oversees reporting with no regulatory tests whatsoever. What's interesting is that in long-term care facilities were not included in those 2002 requirements. So in 2007, the governor's prescription for Pennsylvania plan amended Act 13 and added a chapter which we call Act 52. So this modification of Act 13 is specifically aimed at reducing and preventing healthcare-associated infections in hospitals and long-term care facilities. So it defines all healthcare-associated infections, which we're going to call HAIs, as a serious event. So Act 52 requires the Patient Safety Authority and the Pennsylvania Department of Health to develop and maintain a list of reportable HAIs in nursing homes. So these criteria also required by law to be consistent with national standards. So this is why we revised the criteria in 2014 to mirror the revised McGeer criteria. So the Act requires Pennsylvania long-term care facilities to report HAIs to the Patient Safety Authority and to the Department of Health via an electronic reporting platform. This has to be done within 24 hours of completion of surveillance and confirmation of standardized criteria. Now, since HAIs are serious events, nursing homes are also required to notify the resident or their legal representative in writing of the infection within 7 days. So what are the criteria for confirmation of a reportable infection? Well, the purpose is to meet the 24-hour reporting requirements for serious events that was set forth by Act 13. So nursing homes must submit their reports of all infections to the Patient Safety Authority within 24 hours of confirmation. So before you report an HAI into PACERS, it's important to understand the criteria for confirmation of a reportable infection. The confirmation is defined as you've completed surveillance, you've confirmed the infection, and that the symptoms, for example, are not due to a non-infectious cause. And this needs to be done according to this criteria that we have selected, which is nationally recognized. And it has to be done by a staff member who's responsible for infection control. That's assuming that that person knows something about infection control. So when you report into PACERS, you'll be asked the confirmation date. So it may be helpful for you to know what confirmation is not. Confirmation is not an end-of-the-month retrospective review of medical records to find the criteria and lab results. It's not saving all your surveillance and lab results until the end of the month to confirm all at once. It's not waiting for your medical director to approve your surveillance once a month. So this is why CMS is soon going to require that the person in charge of infection control has received nationally accepted training. So why does it matter what criteria we use to identify an infection? Well, first of all, your data needs to be meaningful, not just a rote collection of numbers. So we use those national standards for infection surveillance and long-term care here in Pennsylvania. Specifically, we use the revised McGear criteria, which also mirrors the criteria that NHSN or the CDC uses. So it's important to use the criteria that are evidence-based, so you have a harmonization with this nationally accepted criteria. Data that's actionable guides your infection control surveillance activities. Standardized evidence-based criteria has been published for a variety of clinical relevant preventable infections. So you won't find the common cold because we don't really think we could prevent that. The scientific criteria to identify an infection includes not only the clinical presentation, but also the microbiology and radiology information. And of course, standardized criteria promotes early identification of a true healthcare-associated infection and therefore timely intervention. So there are 4 key points to define infections in the elderly. And healthcare-associated infection, or HAI, is a localized or systemic condition that was not present or incubating when they were admitted to your facility or readmitted. All signs and symptoms of an infection need to be acute, new, or rapidly worsening. Non-infectious causes should always be considered before defining an infection. So to standardize terminology and assessment criteria, evidence-based definitions are available for constitutional criteria. We're going to go over those in detail. Those include fever, leukocytosis, and acute change in mental and functional status. So let's start with talking about the constitutional criteria, because they are mixed into the criteria of every infection you're going to be reporting. The knowledge of constitutional criteria is certainly crucial so that you can accurately identify symptoms of an HAI. So identifying a fever in the elderly can be difficult because they often have a subnormal temperature. In 2008, the Infectious Disease Society of America updated the clinical practice guideline for the evaluation of fever related to infection in older adults in long-term care facilities. So for residents to have a fever, one of the following must be true: a single oral temp higher than 100 degrees Fahrenheit, repeated oral temperatures of 99, or more than 99 degrees, or repeated rectal temperatures more than 99.5. It also includes a single temperature that's 2 degrees over their baseline, and from any site that you take it, oral, tympanic, or axillary. If you're using the best baseline definitions, you should use an average of the resident's previous documented temperatures. Make sure you use the same method for baseline as for fever assessment. In other words, everything should be oral or tympanic or axillary. So Rogers we're all familiar with Rogers. Everybody on the line has probably had chills and fever when they've been sick, and our residents can. It is a symptom of some of the criteria for illness, and so we need to make sure that we're looking for that. Another constitutional criteria is the new onset of confusion. Do your nurses and CNAs know how to assess, report, and record an acute change in mental status? Do the charge nurses and physicians know what questions to ask when someone reports that the resident is confused or just not right today? We've taken the criteria from the manual from McGear and put it in these boxes to kind of help you understand and teach people the right thing to do. So to have a true new onset of confusion, it needs to be an acute onset, as we've discussed, but they also need to have inattention and fluctuating behavior. So once they have all three of those, then you want to look for either disorganized thinking or the altered level of consciousness. It's one or the other. This mirrors the MDS, so it wasn't just a made-up definition. A new onset of decline in function can also be indicative of an infection. So it's important to have the information to perform an accurate assessment of those subtle changes that can identify an HAI. The staff need to know how to monitor how much help the resident needs to perform their ADLs on a daily per-shift basis. And only by knowing their baseline can you determine if they have a new decline in function. So there are 5 levels of assistance, the same as in the MDS. Each level corresponds with a number 0 to 4, 4 being the most dependent. So it's important to educate your staff on how to monitor the change in functional status. And the managers need to determine reporting and documentation mechanisms for your facility to be able to capture this information on a per-shift basis. So the reporting criteria for several categories of HAIs include a functional decline. Now, if you follow the PACERS manual, you'll see that a new onset of functional decline requires a 3-point change in staff help with ADL. We follow the McGear, which follows the MDS definitions. So here's an example of an 8-point decline in the resident's ADL function over the last 7 days. So if the resident, this resident definitely needs more staff help in all the ADLs, except for eating, and this will qualify them for a new onset in functional decline. Once you have that change in mental status or change in functional status, both of those, both the acute onset of confusion or the acute onset of functional decline, will fit the criteria only if the symptoms are accompanied by leukocytosis. So just a quick primer for those of you who may not be sure how to use this. The CDC with the differential measures the levels of white blood cells. It's often ordered as a screening test to help detect infection. Leukocytosis is determined by high numbers of white blood cells, which may indicate inflammation that may be associated with an infection. Leukocytosis is determined by neutrophilia with greater than 14,000 leukocytes or an elevation in immature white blood cell count, or bands. This is demonstrated by a left shift with greater than 6% bands or greater than or equal to 1,500 bands per milliliter. What does that mean? Well, less mature neutrophils, baby white blood cells, are those that have recently been released from the bone marrow into the bloodstream. They're known as bands. And this term, shift to the left, simply means that the bands have increased, indicating an infection is in progress. The white blood cells you have circulating aren't doing the job. The infection is calling for more troops, so the baby white blood cells are sent out to help with the infection. Let's see if I can. There we go. Okay, so costovertebral or CV angle is the area, where the vertebral column or the spine intersects the lower ribs. Why do you need to know this? Well, it's an important area because it marks the spot where the kidneys are typically found. Because of the referred pain pathways, even a simple lower UTI may be accompanied by flank pain and CV angle tenderness. Percussion of the kidneys, as demonstrated here, helps assess CV angle pain or tenderness. And this is important if it's the only symptom that your resident has that would be a symptom of a UTI. So healthcare professionals often check for tenderness in this area by tapping a fist on this region of the body. If the maneuver elicits pain, positive CV angle tenderness is said to be present. Typically, a nurse or physician would check for tenderness both on the right and left sides of the body. So something to make sure everybody knows how to do, have them practice it so they're comfortable with this process. So our second objective is to clarify site-specific surveillance for definitions of common clinical syndromes. So let's go through all the criteria for each of the reportable infections. So first we have here symptomatic urinary tract infection. Now, all of the symptoms other than pain can easily be identified in a resident with dementia, not only for urinary tract infections, but for all infections. While it may be difficult to assess pain in residents with dementia, we want to consider assessing the effects of pain, agitation, aggression, crying, or anxiety. It can help you assess for pain. So both for a symptomatic urinary tract infection, both criteria 1 and 2 must be present. So for criteria 1, we have criteria 1 and actually 1A. You're looking for acute dysuria, pain, swelling, or tenderness of the male genitalia, or fever or leukocytosis, and at least one of the CV ankle pain or tenderness, gross hematuria, suprapubic pain, and the new or marked increase in incontinence or urgency or frequency. Now, if they don't fit that criteria, then you can use criteria 1A. Then you only need 2 of gross hematuria or one of the other 3, incontinence, urgency, or frequency. All of the criteria are accompanied by lab or radiologic criteria to identify a true infection. So for a symptomatic urinary tract infection, we're looking for, if you take a voided urine, you're looking for 100,000 colony count of no more than 2 species of microorganisms. If you use a straight in and out catheter specimen, you're only looking for 100. 10 to the second power is 100 colony-forming units. One of the organisms must be a bacteria. Yeast and other microorganisms that are not bacteria are not acceptable UTI pathogens. Urine culture results are acceptable criteria only if there's at least 1 qualifying bacteria and if it's not contaminated with 3 or more organisms. So both criteria 1 and 2 must be present to identify a catheter-associated urinary tract infection. Rigors, as we discussed, the chills and fever, low blood pressure, fever, and of course we're wanting to make sure that there's no alternative site of infection if they have those symptoms. You're looking for the constitutional criteria, the confusion, functional decline, fever, those kinds of things. And you're also looking for, you could also have purulent drainage at catheter site or that acute pain or swelling of the male genitalia. The lab requirements for a cavity are a urine catheter sterile specimen with at least 100,000 colony counts of any organism. A fever can be used to meet a cavity criteria even if the resident has another possible cause for the fever, like pneumonia. A urinary catheter, that's what you'll believe that we still have to talk about this, but we do, is defined as an indwelling device that's inserted into the bladder through the urethra, left in place, and connected to a closed collection system. Those are the only types of catheters that we are using for reportable catheter-associated UTIs. Indwelling catheters do not include straight in and out catheters or suprapubics. Criteria 2 says any organisms. This does not mean multiple organisms. In 2016, the CDC clarified culture results to state there must be at least 1 bacteria identified to qualify as a cavity. And the revised McGeer criteria, which came out in 2012, states that any catheter that's been in place for more than 14 days should be replaced before obtaining a specimen for culture. It should also then be refrigerated and to the lab and cultured within 24 hours. Onto a beauty. So for an asymptomatic bacteremic urinary tract infection, we're looking for a positive blood culture with a matching organism in the urine. If it's a voided or an indwelling catheter specimen, you're looking for 100,000 colony counts. If it's straight in and out, you're only looking for 100. Again, yeast and other microorganisms other than bacteria are not acceptable UTI pathogens, and urine culture results are acceptable only if there's a qualifying bacteria. So criteria 1, 2, and 3 must be present to identify a lower respiratory tract infection. And you'll notice with this in the next slide that the criteria all look the same, and there are some subtle differences. For a lower respiratory tract infection, there was no chest X-ray done or it was negative. And you have to have 2 of the symptoms in criteria 2, the high respiratory rate, chest pain, lung exam or abnormalities, there were increased sputum or wet cough, and, of course, a decreased O2 set. The criteria 3, at least one of the constitutional criteria. But when you get to pneumonia, do need the chest X-ray. That is positive for pneumonia or a new infiltrate. The criteria 2, the symptomatology, they're only asking for one of those. And the criteria 3 is the same as it is for LRTI with the constitutional criteria. So underlying conditions such as congestive heart failure or interstitial lung disease could mimic the presentation of lower respiratory tract infection. So non-infectious conditions should be excluded by review of the clinical records and assessment of signs and symptoms. You may have to talk to your medical director, kind of figure it out. Pneumonia can be tricky. Both criteria 1 and 2 must be present to identify an influenza-like illness. You need to have fever and at least 3 of the symptoms of chills, headache, eye pain, body aches, malaise, loss of appetite, or sore throat. So you want to make sure that people are looking for these things so you can actually accurately identify an influenza-like illness. If the resident has a positive test for influenza, the reporting system will allow you to enter the influenza without any symptoms. So both criteria 1 and 2 must be present to identify Clostridium difficile infection, or CDI. So we need to have a stool sample for this positive for C. diff toxin, or a stool culture or molecular testing for the C. diff organism. Or, and this would probably most likely be found in the hospital, an endoscopic examination, certainly the surgery, the biopsies, that would identify pseudomembranous colitis. It also has to have criteria 2, so you want to have diarrhea in the absence of vomiting, or that positive radiologic test for toxic colon, which again is something that's most likely done in the hospital. So just a couple words about CDI. Primary CDI occurs without any previous history of CDI, or more than 8 weeks after the onset of a previous episode. Recurrent CDI occurs 8 weeks or sooner after the onset of a previous episode, if the symptoms from the previous episode have resolved. Residents previously infected with C. diff also may continue to remain colonized even after symptoms resolve. So in the setting of an outbreak of GI infection, individuals could have positive tests for the presence of C. diff toxin because of ongoing colonization, but they can also be co-infected with another pathogen like norovirus. Speaking of norovirus, you can identify it using criteria 1 and criteria 2. So for both criteria 1 and 2, you need to have diarrhea and or vomiting. For number 1, you need a stool sample. As we know, you get the stool sample, the state labs only want a couple of them and takes them forever to get back to you. For criteria 2, you can identify through the clinical symptoms, and that's the Kaplan criteria. I listed the Kaplan criteria here for you, and people seem to have some difficulty with this. Not so much the vomiting and the incubation period, the duration of illness. As long as you've got people accurately documenting on a line listing every shift what's happening, you can pretty much keep track of that. But the no bacterial pathogen identified in the stool culture is meant to mean that if you didn't do a bacterial culture looking for salmonella or ovum parasites or something else, or you did one and there wasn't any bacterial pathogen identified. So another note, an outbreak, which is 2 or more cases of acute gastroenteritis, may be assumed to be present if all the Kaplan criteria are present. So what's diarrhea? 3 or more liquid or watery stools above what's normal for the resident within a 24-hour period. Vomiting is 2 or more episodes within a 24-hour period. Bacterial gastroenteritis is identified by negative C. diff, and a stool sample is positive bacteria, nausea, vomiting, diarrhea, or abdominal pain or tenderness. So effective surveillance will exclude non-infectious causes of symptoms like new medications, dietary allergies, or tube feedings. Now, if you're having an outbreak, stool specimens should be sent to confirm the presence of a pathogen. And again, you may be looking for other things like ovum parasites, Shigella, rotavirus, or E. coli 0157H7. A skin and soft tissue infection is identified by positive the wound, skin, or soft tissue site. It can be identified by 4 symptoms other than pus. So you're also looking at heat, redness, swelling, tenderness, serous drainage, and of course, one of those constitutional criteria. Wound infections that are related to surgical procedures should be reported back to the institution where the procedure was performed. One of my favorites, identification of scabies requires a maculopapular or itchy rash, and a diagnosis by either the physician's clinical decision, you've confirmed it by the lab, by scrapings, or there's an epidemiologic linkage to a case if there's evidence of a common source of exposure, living on the same unit, eating in the same dining room, being in the same room, for example. So you want to make sure you rule out rashes due to skin irritation, allergic reactions, eczema, psoriasis, and other kind of normal skin conditions. To accurately identify conjunctivitis, the resident must have purulent drainage from the eyes for 24 hours and conjunctival pain or erythema. Note, you want to rule out allergic reactions or trauma, including blepharitis, which is an inflammation of the eyelid. The last category of reportable HAIs are device-related bloodstream infections. You're looking for bloodstream infections related to dialysis lines, temporary or permanent central lines. Now, central lines terminate at or close to the heart or in one of the great blood vessels. They are used for infusions, labs, or hemodynamic monitoring. So a temporary central line would be something like a PIC. Hopefully the hospital is not sending you back with residents with internal jugulars, such as Palladians or femorals. Midlines are not central venous catheters, and if you're not sure what a midline looks like versus a PIC, you need to make sure that the information from the hospital tells you what kind of a line it is. And so central line-associated bloodstream infection, or CLABSI, is identified by criteria 1 or criteria 2. So criteria 1 is they have a recognized pathogen in one or more blood cultures, and the organism is not related to an infection at the other site. Criteria 2, now they're looking for symptoms, fever, chills, or low blood pressure, and the organism is not from anywhere else. But they also talk about common commensals being cultured from 2 or more blood cultures drawn on separate occasions. Well, again, what is that? So a common commensal is a microorganism that lives continuously on or in certain parts of the body that don't cause disease. Commensals may cause disease if they gain access to parts of the body other than their normal habitat. So we provided a full list of CDC-identified common commensals with the handouts for this session. So we'll leave time for questions at the end of the presentation, but first I'm going to turn the presentation over to JoAnn so she can talk to you about ways to track, validate, and utilize HAI data. JoAnn?
Thank you, Sharon. So we're going to move on, and I have a polling question for you. Karen, would you please open the poll? And I'd like you to take a few moments and answer this poll. What is your biggest challenge in identifying an infection? Documentation does not note the resident's symptoms. You were not notified of a culture or testing being performed or of a change in your resident's condition, or you have difficulty applying the criteria. So please take a moment and vote, and we're going to discuss these challenges and some ways to address them. So if you haven't voted, would you please take a minute to vote for the polling question? And then we'll review the results. Karen, you can close the poll. But we're going to further discuss in the second half of this webinar some difficulties you may be having with performing surveillance, ways you can analyze your criteria, and then some educational tools we have available for you through the Patient Safety Authority. So when I look at the results of your poll, documentation that does not note the resident's symptoms seems to be the biggest challenge that everyone is facing. Whoops, sorry, I got ahead of myself there. So how do we apply this to practice? What do you do with the information you've collected, and how do you use it to enhance resident safety? Listed are some of the problems that may be encountered when investigating a potential infection and applying the criteria. Elderly clientele can be a problem, poor communication, inadequate surveillance, unfamiliarity with the criteria, and poor documentation. And I'm going to be discussing them in further detail. Typical signs and symptoms seen in younger adults may be diminished or absent in the elderly, such as fever and leukocytosis. Only 60% of older adults with infection develop leukocytosis, but its absence does not rule out an infectious process. Also, frail older adults tend to have poor body temperature response, so a fever 2 degrees above baseline should be considered a febrile response. For example, if you have an elderly resident that runs a normal baseline temperature of 97.6, and when you take their temperature, it's 99.7, that is a significant fever for them. Changes caused by infection are subtle, and nonspecific complaints may be the only indication. A change in mental status or a decline in function may be the only presenting symptom. So when you have a resident with dementia, how do you identify symptoms when the patient is unable to verbalize them? That's when a complete nursing assessment or evaluation is essential. Communication is a two-way street. Good, effective communication with coworkers and providers is a benefit. For example, your certified nursing assistants can provide information of subtle changes to help identify potential infections early. Shift handoff and huddles provide an opportunity to discuss potential changes or possible infections. And as Sharon had stated earlier, make sure your staff are educated on the signs and symptoms of the criteria to help promote communication and buy-in. Early identification of changes and good communication improves outcomes by early identification and treatment of infection. Inadequate surveillance is a barrier to identifying a healthcare-acquired infection, and surveillance is a learned skill. In performing surveillance, you should ask yourself the following questions. Is there a change in the resident condition? Do they have pain? Did you check for suprapubic or costovertebral angle pain? Do they have a temperature? Was any testing performed? If so, what tests were ordered and what are the results? And was any treatment ordered? What does your staff need to know to assist you in infection identification and reporting? Well, they must know the McGear criteria. They need to know out of the criteria what constitutes an infection and when to ask for testing. Along with the criteria, they also need to know what documentation requirements are necessary, what are the reporting requirements, what are your infection prevention policies. And the reason why I say that is if they notice someone having severe diarrhea that cannot be contained, are they putting that resident in precautions? And they also need to know how to do a physical assessment or evaluation. Documentation is essential in identifying potential infections and applying criteria. Staff need to know the where, what, when, and why of documentation. They need to know what to document, such as what signs and symptoms are they observing. They need to know where to document. They need to document in the proper place so it is easily found when you do your surveillance. They also need to know when to document, and they need to document as it is identified. For example, you may have a resident admitted to you with diarrhea, but no one documents it until the 4th or 5th day the resident is in your facility. At that point in time, it is documented, and the nurse requests and sends off a stool for culture, and the patient is then placed in screening. However, they come back positive for C. difficile. So you've had late testing, and now it is not only your healthcare-acquired infection to claim, but you've had potential exposure because the patient was not placed into precautions. And they also need to know why they are documenting, why it is important to have good documentation to assist you in identifying infections. So I'm going to do another polling question. So Karen, please open the poll and take a few moments to answer this question. With which methods does your facility use to track and analyze the number and types of healthcare-acquired infections? Do you use PACER analytic reports and graphics? Do you use an Excel spreadsheet, lists, and graphics? Do you have a line listing of residents on antibiotics? Do you have corporate-based tools, or do you not have a formal method established? So please take a few moments to answer the question. And I just want to reinforce what Sharon said. Infection prevention is more than just collecting numbers. You also need to analyze your data, which will drive improvements in resident safety. So I'm going to give you a couple more seconds here to answer this poll, but we're going to be going on further then to talk more about surveillance. So Karen, would you please close the poll and we'll see what the results are? And it will be interesting to me to see from the facilities what most of you use. And it's actually pretty equal. A third of you uses a line listing of the residents on antibiotics. We do have about 25% that use an Excel spreadsheet, and another 20 to 25% that actually use the PACERS analytics. And that's great because I'm going to go through the PACERS analytics and what's available for you if you so choose to use it. And we do have some facilities, about 10%, that have corporate-based tools. But I'm very happy to say everybody is using some type of method. So let's talk about surveillance. It's important to understand that surveillance is more than collecting events and reporting them into PACERS. Surveillance is a multi-step, essential component of an effective clinical program. It's designed to reduce the frequency of adverse events such as infections. Surveillance is defined as the systematic collection, analysis, interpretation, and dissemination of data. Surveillance provides information to members of the healthcare team to assist in measuring and improving outcomes, processes of care, and facility systems. Surveillance is necessary for accurate quantification of events and demonstration of process improvement. So what does surveillance include? Well, it includes assessment and auditing, which can be done by an Excel spreadsheet or line listing. It also includes feedback to quality assurance and process improvement committees, to your staff, to providers, and also to residents and families. If you provide feedback of your infection rates to your staff on the individual nursing units, it promotes buy-in and compliance of procedures. Physicians need to know what your infection rates are to help drive improvement. And it's also nice that when you have decreasing rates, to celebrate that with your residents and families. Everyone is a shareholder in this. This is an example from AHRQ, the Association of Healthcare Research and Quality, of a line listing to assist in performing in surveillance. And you may be using something similar in your facility, either as an Excel spreadsheet or on paper. But when you look at the information on here, most of them contain the same things. You always have the resident and their identifier, room number, admit date, prescriber, and then symptoms and laboratories done in the results and whether it met criteria or not. This one also includes antibiotic listing, if they were started on an empiric antibiotic, and if a timeout was done, because all of that are pieces of antibiotic stewardship. So I want to talk a little bit about what is available in PACERS to assist you. Are you aware the PACERS system can assist in analyzing your data? What this is a screenshot of is the page of PACERS when you first sign in. And if you go across the blue bar on top, you will see one that is highlighted there with the red arrow that says Analytical Data Tools. This then gives you the drop-down menu, and you can pull up individual resident infection reports, or you can analyze your facility's data. And that's what I'm highlighting with the red arrow, is if you click on Event Report Data Analysis. This analysis can be done in table or chart form that you can then copy and use at your QAPI committee or unit feedback. And I'm going to show you some of the information that is available in the PACERS analytics. This is an example of a utilization data in table form. This is the information you enter monthly on resident days and central line days. And I'm showing you 1 year here. This is a fictitious facility, and this is 2015. And you can see what their central line days were for that entire year per month, and when their rates for utilization were up or down. And then the next table I'm going to show you, this is actually a chart from my fictitious facility of urinary tract infections for 1 year. When you look at this chart, the red line at the top is a peer group infection rate. Pacers provide you with a benchmark that you can compare your rates to your peer group. And I'm sure most of you would agree this would be very valuable to you and your administration to see what that comparison is. When you look at our graphics, the solid blue line is your infection rate, and the lighter blue line is the actual number of infections. But it gives you a very nice comparison of where this facility is with urinary tract infections compared to their peer group for the state. Then on the next slide, I took both of those types of available graphics and combined them into one report. And the reason I did this is it makes a very nice visual with the chart at the top of progress, and this is looking at urinary catheter utilization rate. So for the people who just want to take a quick look and see if you're increasing or decreasing in your device utilization, they can do this. But then I also included the table at the bottom because you will always have people that want to see the actual numbers and the actual data. They want to see what that actual rate is. Where at the top you're getting the quick visual, you're getting the actual numbers at the bottom. And that's sometimes valuable to report out for people in one graphic when you're doing your QAPI reporting, because then they have all the information they need. So I'm going to do one more polling question. Well, this is two more, because I find polls to be very valuable. Karen, please open this poll. And I want to know how your healthcare acquired infection data, your HAI data, is used in your facility to target opportunities for improvement. Are PACER reports and graphics presented at QAPI for discussion? Does your infection prevention designee perform data integrity validation? Are your HAI trends tracked on a dashboard? Are they discussed with clinicians? Or is your HAI data not analyzed for trends? So please take a moment to answer that poll. PACER's data can be used for QAPI reporting. Quality assurance and process improvement is data-driven. It's a proactive approach to improving the quality of life, the care, and to decrease infections. And PACERs provide the data source to monitor these process and outcome measures. It also helps analyze trends and opportunities for improvement are identified. The PACER's analytics and assessment tools target specific areas to direct analysis, gap analysis. So we're going to close the poll here momentarily, so if you have not voted, please do so. And we'll take a look at the results. And almost 50% of you do use the PACER's reports and graphics to present at your QAPI committees for discussion, which, coming from me at the authority, makes me happy for two reasons. Number one, that you're using our system, but more importantly, it provides very nice, concise graphics for your use. A quarter of you, 25%, the IPD performs the data integrity validation, and we do have about 5% of you that track it on a dashboard, and about 10% that discuss it with clinicians. So it looks like everybody is doing some part of validation and analyzation. So I just want to reinforce what Sharon did. And Sharon did an excellent job of explaining the McGeer criteria. But I want to emphasize the importance of teaching this to others. Make sure your nurses and your CNAs are familiar with the criteria. Make sure they know what signs and symptoms to look for, because you do not want them asking for additional testing if the resident is not symptomatic. Knowing the criteria will also help guide their documentation to help you determine an infection and if it was present on admission. And I promise, last polling question. Karen, please open the poll. Have you ever used the authority's Learning Management System, or LMS, for education on PACERs? Yes, I have completed many training sessions. Yes, I have completed 1 or 2 sessions. No, I have not used LMS, or what is LMS? And these last couple slides, I want to briefly review the Learning Management System. It is an online educational system available to you and your staff. It has multiple training sessions and has education specific to PACERS reporting and infection prevention. So I'd like to get a handle on how many people have actually accessed the learning management system and utilized it. And then we're going to show you how to access it for you or your staff. So Karen, you can close the poll and we'll see how many people know what LMS is. But we're going to go ahead and show you what the LMS system is because I think it's very valuable and very important. And it looks like over half of you have never used the LMS system or know what it is. We have approximately 10% of the people that have done 1 or 2 training sessions, but for the most part, you are not aware of it. So this is a learning management system, and it can be accessed through the PACERS website. When you go across the blue bar at the top, you'll see the Resource tab, and when you click on that, you'll get this drop-down menu. When you scroll down, you'll see where it says Long-Term Care HAI Reporting Training. Click on this, and it takes you to the sign-on page or the home page. And this is what that page looks like. If you have never accessed the learning management system before, you will need to register, and that can be accomplished by clicking on the registration link in the right upper corner. If you have previously registered, then you need to just sign in. After you successfully sign in, this is the home page, and I've enlarged what's on the left-hand side of the screen. To access the courses, you click on the learning catalog from the list on the left, and that is what is highlighted with the red arrow. Once you click on that, it opens up the whole learning catalog, and there are multiple sessions available to you. So you select the training module you're interested in. I enlarged the session that includes the PACERS analytics, and when you look at this slide, it's the second selection down. As we briefly reviewed the analytics available, if you select this link, it will take you to analytic training, and this training will help you become more familiar with the many functions and graphics available in PACERS. But your staff who may not have PACERS access are also able to use learning management system. And I encourage you to use it to assist in staff education. So you want to know how your staff can access it. Well, this resource page has 3 links to assist you, and I think they're valuable for you. The first link is the authority's website, and our website has a variety of resources, articles, and tools available for your use. The second link is a link that will direct you or your staff to the LMS sign-in page. So you do not have to be able to log into PACERS to enter infections. You can give this to your staff and assign them what sessions you would like them to complete. When you click on this, they'll get the sign-in page. They will have to register, but then they will be able to access all the sessions. And we at the Authority also record our webinars, and they're available by YouTube at the link provided. So what questions do you have for us? Terry Lee, I'm going to turn the program back to you.
Thank you, ladies. Sharon and JoAnn, that was a very informative presentation. It contained valuable information that I hope everyone can use in their organization. This concludes the slide portion of our program. Now we would like to begin our question and answer period. The first question I have, Sharon, I believe will be for you, and if I understand what our participant is asking, is there was a change in the way we call a CAUTI infection. If, for example, a resident has another serious infection, such as a wound infection, and they have a fever, may you use the fever as part of their criteria to call the CAUTI infection?
Hi, thanks for your question. Yes, the change in the CDC criteria does allow you to use a fever that could be attributed to another condition that the resident is currently suffering from. They're not making you try and figure out if the fever is from the pneumonia or from the urinary tract infection. If you have the other criteria, then you can use the fever for either or both.
Thank you. The next question for you, Sharon, is there clear guidance as to the length of time after admission that a particular infection becomes an acquired infection for the admitting facility versus the facility where the resident was transferred from?
It's an excellent question. And it used to be, okay, we had 3 days or 2 days, and that was it. It was not yours. But it really depends on the type of infection. And, for example, if the person was in the hospital and had a catheter removed in the hospital and they had catheter-associated urinary tract infection, its symptoms when they got to your place, if it's after 2 days after admission, then it's yours. Before, it belongs to them. On the other hand, some other infections, especially when you get into the admission, readmission, you have to carefully look at your symptoms and determine, based on the criteria or with your medical director, if these symptoms could have been incubating prior to admission. Now, a good resource is, of course, our manual, but since we're not able to train everybody to the process of being an IP skilled at surveillance, it takes a little bit of time to get used to be able to do this. I would suggest that for whatever particular infection you're looking at, you go into, you can Google NHSN, National Healthcare Safety Network. When you get in there, look for long-term care facilities. It says enrolled, but even if you're not, it doesn't matter. And look in there. They have some modules stood up for UTIs. But you can also look at the other modules for like bloodstream infections or respiratory infections. There's a lot of guidance in there, and they do have a lot of information about present on admission. And unfortunately, it does differ depending on the type of infection. And JoAnn, do you have anything to add to that?
No, I do not, Sharon, not at this point.
JoAnn, when we were talking about on the analytics that Pacers will provide you with comparison to your peer group, do you know how that peer group is determined? Is it all nursing homes, or is it based by size of nursing homes? Are you able to give us any more definitive information on that?
It is all nursing homes. I do not believe it is broken down by size of nursing homes. Sharon, can you comment on that?
Actually, it is. It was the only way.
Thank you.
It was the only way we could risk adjust. We did not risk adjust based on types of facilities like ventilator facilities versus custodial care facilities. We really weren't able to drill down that far, but it is by size, which is the only comparison that we can use.
Okay, and then
Thanks.
The next question for the analytics is how do you isolate data information per unit?
That is when you go into the analytics, and I did not get into this with this program because that would be an entire hour lecture. But when you click into the Pacer Analytics, you will have a choice of what infections you're wishing to look at, because you can look at individual infections or you can look at your overall facility infection rate. But if you choose an infection, then you can modify the criteria and select what units you would like to see just that infection rate. So if you have further questions on that, I strongly suggest you take the Learning Management Systems session on Pacer Analytics, or you can contact Sharon or I, and we can work with you on that.
This is Sharon. The help desk can also assist you with that, with finding the right place. But I will tell you that the one report that has every infection in it that you can drill down to the infection, the subtype, and the units is called the Infection Awareness Report.
Okay, and we are now at 2 o'clock. However, I am going to take one last question because I think it may give you some information that could answer some of the questions that we couldn't get to. We have a participant that is new and would like to know where to find the reporting systems forms, like the infection forms. So if we could let her know how to access those, many of the questions that we are not getting to, if the other participants were to go in to review those, I think they would find their answers.
I can take this, JoAnn. There's two places where you can look. When you log into Pacers, the same way you would go in to put in an infection, if you go to Resources, you will find the user's manual, which we keep up to date. If anything's revised, it's always on the electronic version. And also in there are blank forms, which you can print out and use to collect data.
Thank you, Sharon. This concludes our webinar. Have a good afternoon.